Thanks very much. I'm very happy to be here today. I'm really happy to see how well this group is growing. I'm very happy that John couldn't think of another introduction for me. He's making me really nervous. And I'm happy, so happy to see such wide, a lot of countries represented here. And I'm happy to have an easy job. I'm following two fantastic speakers, and I see some very good speakers this afternoon. I'm also happy that in the context of giving this talk, I cannot possibly cover in 20 minutes, it's 16 minutes now, and 20 slides, the current and planned clinical trials in MPN. This is a very busy, active area at the moment. So I've chosen to just pick a few key messages and tell you where I think we're going. Ruben and I shared our slides, and I'm not going to touch on interferon because Martin did a great job. I think it's important to acknowledge that all of the clinicians who are speaking have relationships with industry, and those relationships are really important. Because in that way, then we can work to try to participate and develop jointly clinical trials to do the kind of studies that we're talking about, Pegasus and ruxolitinib, for example. Those are both investigator-led studies. That means a study that an academic group has come up with, not a commercial study. This is the brief outline that I'm going to talk to today. I'm not going to mention interferon because Martin did that already very nicely, but we really need more mature data, and we need to make sure that we still have access to interferon. Ruxolitinib and MDM2, Ruben touched on MDM2 a little bit, and then I'm going to talk about myelofibrosis and the stem cell niche. I'm not going to talk specifically about the rare MPN at the bottom here, but there are diseases that are much rarer than MF, ET, PV that fall under the MPN umbrella, and we should be thinking a little bit about folks with chronic neutrophilic leukemia, chronic eosinophilic leukemia, etc. And there are studies in these diseases and indeed in mastocytosis. I want to share the results of an old study with you that were just published this week in the Journal of Clinical Oncology. This is a study that is 20 years old. And this is a very big study that's happened in the UK, France, and Australia. It's a PT1 study, which is an ET study, and it has a very important message. So I want to share this with you to illustrate, one, the importance of long-term studies, quite simple studies, and to share the message from this study, which is, I think, very important. So we know from what Martin said and from our own experience about ET that we usually only treat patients who are at high risk of thrombosis, meaning those patients who are age over 60 or have had a previous thrombotic event. And more recently, our guidance suggests that we should be paying a little bit more attention to those patients with the JAK2 mutation. For patients who have low-risk disease, lacking either one of those features, we have no data to suggest whether using an agent like hydroxycarbamide or indeed interferon might be beneficial. So we decided to study patients who are aged between 40 and 59 who have a higher background risk of thrombotic events and ask, could we do them any benefit by controlling their blood count? And so this is known as the intermediate risk, because these are not quite at low risk patients. It's a prospective study that we started in 1997, and it was a randomized study, and we compared in these patients hydroxycarbamide plus aspirin with aspirin alone. And the patients could have already had the disease for a long time, could have already been on a drug. And the endpoint of the study was to look to see if we affected the risk of having a blood clot, having bleeding, or dying from a vascular cause. And then we also asked a question about whether adding hydroxycarbamide might reduce the risk of myelofibrosis, increase the risk of leukemia, and we looked at quality of life. We certainly saw that the patients who were treated with hydroxycarbamide, the kind of bluey purple bar here, had a lower platelet count, a lower hemoglobin and a lower white cell count. We saw, though, that there was no difference, so there was no benefit of adding hydroxycarbamide in terms of preventing thrombosis, hemorrhage or vascular death. We also saw that the event rate, so the number of these events, was quite low. So it was much lower than we expected when we planned the study. It was less than 1% per year. So this is a very important finding when we're talking to people who are diagnosed with this disease aged between 40 and 59. We also found that there was no particular association with mutation status, so this questions some of the current thinking about JAK2 patients being at higher risk, gender, blood count at diagnosis, and there was no difference when we censored the patients, either when they changed treatment or when they reached age 60. We also saw no difference in disease transformation. Here you see the different events at the bottom of the slide. Slightly more myelofibrosis in the untreated patients, but this was not statistically significant. No difference in acute leukemia, no difference in myelodysplasia, but slightly more polycythemia vera, probably because hydroxycarbamide is suppressing the red cell count increase that, as Martin said, can happen sometimes for these patients. What about adverse events? No difference in minor hemorrhage, and importantly, because this is a concern, of course, with hydroxycarbamide, no difference in rates of non-hematological cancers. So this is very important because it's a big study, 380 patients, long follow-up, and basically challenges that we should not be just treating these patients on the basis of having a high platelet count, and that we should only give aspirin. Also provides some data on the long-term safety of hydroxycarbamide, which is a concern for many patients. On the back of this study, we've also done many molecular studies and done many correlative studies, and there will be some further data coming with regard to impact of molecular markers, but I've given you a heads up, they don't seem to make any difference. What then, continuing the theme of ET, what about second-line therapy and what about JAK inhibitors for ET? So we've seen that ruxolitinib's been developed for MF, then PV, but what about testing ruxolitinib in ET? So there was one study from Serge Verstovsek. There is a current study that's about to be launched in several countries looking at ruxolitinib versus anagrelide, which is another therapy we know we can use for ET patients. In the UK, we did the so-called MAGIC study comparing ruxolitinib with standard therapy for second line and saw no difference in control of blood counts, no difference in survival, but some benefit for symptoms. There are many other second line agents that can be used. Further data from the MAGIC ET study has given us some important insights into the role of these other kind of bystander or so-called non-driver mutations. So we've learned that in myelofibrosis, if you have a high molecular risk mutation like ASXL1, for example, that could mean that you're at higher risk and could mean that we should be considering more intensive therapies. At the moment, that would be transplantation. But we don't know very much about that for ET and PV patients. In this study, we were able to show that the patients with ET who had these additional mutations, they had a worse survival. So this might start us to be thinking about doing these additional molecular tests in patients with ET, as well as probably patients with PV. Importantly, this difference in adverse survival was not present for patients treated with ruxolitinib, but it was present for patients with best available therapy. And we were able to identify some particular bad guys in terms of the mutations. So TP53 and SF3B1 are mutations that appear to be particularly bad. So not only are we learning things about treatment, but also about biology. There's some other important observations about biology of these diseases just to share with you. gender differences are inherent between the rates of presentation of these diseases. And I seem to remember 2 years ago standing up and talking about differences between men and women in MPNs. Recently, there's been some very nice work presented looking at estrogen, so the female sex hormone, signalling and its effects upon hematopoiesis. It also appears that tamoxifen, an anti-estrogen drug used in breast cancer treatment, can affect stem cell dynamics. And we've asked the question, can we exploit this in the context of a clinical trial, particularly looking at JAK2 positive MPN? And we have a trial currently ongoing using this simple, cheap agent in the UK. So JAK inhibition for PV has had demonstrated benefit in terms of controlling blood counts, improving quality of life. There are hints, but no conclusive data regarding reduction in thrombosis or disease transformation. Particularly, there are hints about thrombosis, very little data about disease transformation. In the corollary study in the UK for PV to the MAGICS ET study, we showed that there was a benefit for ruxolitinib in controlling blood counts and symptoms. We also found that ruxolitinib was associated with a longer time to treatment failure. This is a novel finding. We saw symptom improvement. We saw the same rates of thrombosis, but for the first time we were seeing a hint to reduced risk of transformation. In the coming months, in fact, hopefully by the end of next month, we will be starting with funding from MPN Voice and from Novartis and from the French research foundation, INCA, a Mithridate multi-centre study looking at ruxolitinib upfront for PV patients. I have to say, I can't claim any credit for the naming of this study. This was done by Jean-Jacques Lagen, who's got a much better classical education than I do. What about other therapies? So we know about ruxolitinib. We know about the benefits of this drug for patients, as summarised in this slide. But there are still challenges for myelofibrosis patients, treating early disease, management of overlap syndromes, management of toxicities, or management of patients who've got not such a good blood count at the beginning. How do we define progression on ruxolitinib, and how do we manage blast phase? And in 4 minutes, I'll try and touch on that. So there is anemia is a very common problem for patients with myelofibrosis. We can manage this with blood transfusion, but that has its own toxicities and is time-consuming. There are novel agents called activin type 2 receptor antagonists, such as luspatercept and its sister compound, sotatercept, which are currently being tested in this setting. And there is a large 90-plus patient study with luspatercept that is almost completed, sponsored by Celgene, and we will await data with bated breath. I suspect that data will come next year. What about patients who stop ruxolitinib? Certainly for some of these patients, prognosis can be very bad, especially if they have some of the bad guy mutations, that's as shown on the right-hand side of the slide, or if they happen to have a very low platelet count at the time when the drug is stopped. So what about other JAK inhibitors that might be usable either instead of ruxolitinib up front or after ruxolitinib failure? And there are a number of different compounds that I'm just going to touch on very briefly. Firstly, pacritinib. Ruben and I and others have been involved in the development and testing of this drug, which has reached phase 3 clinical trials with positive outcomes. But there were questions about potential bleeding risk for patients with this drug, and also cardiac toxicity. Cardiac toxicity has been completely refuted, and the drug is currently in a dose-finding study and proving successful for many patients. This agent is particularly of interest for patients with low platelet counts, in which it was specifically tested in the PERSIST-2 study, which you probably will remember, which was published earlier this year. And it will likely find a niche in the market, at least for thrombocytopenic patients. And this is really, really important because it's very difficult to manage patients with ruxolitinib when their platelet count is low, and or for second-line use. The next JAK inhibitor, momelotinib, unfortunately, probably related to study design, is currently halted in development because of failure to demonstrate superiority in some aspects of the clinical trial design. However, this drug does have a relatively unique benefit for patients in that it appears to be associated with increased hemoglobin, and that probably relates to hepcidin, the molecule, again, that Martin was mentioning earlier. Recently, in the last couple of weeks, it's been announced that another company, which in fact the people involved in that company were originally involved in the development of momelotinib, has picked up this drug and will probably be working in partnership with Gilead to look at further development. Lastly, fedratinib, another JAK2 inhibitor, positive findings from a phase 3 study, positive findings second line, has been acquired by Celgene. This drug does cause GI toxicity and was halted in clinical development because of the development of Wernicke's encephalopathy. Now, there were 8 patients with potential Wernicke's encephalopathy, but a review demonstrated that only 1 patient had Wernicke's encephalopathy. This is a brain toxicity caused by deficiency of thiamine, which is a vitamin. This patient was not eating properly, had a lot of nausea and vomiting, and we will need to watch this agent as it is developed further by Celgene to see what the prevalence of this toxicity, if any, actually is and how it should be mitigated. So there will be trials with pacritinib, fedratinib, and probably again with momelotinib coming. What about other targets? Well, Ruben's touched on some of these. We've talked about estrogen signalling in that stem cell niche. I want to just tell you a little bit about BET inhibition. And coming probably at ASH will be further data with imetelstat, the telomerase inhibitor that Ruben mentioned. And later this year with the pentraxin analogue, which targets fibrosis. Ruben talked about the MDM2 inhibitor idasanutlib. There are at least three different MDM2 inhibitors. They target the death pathway. Just to highlight to you that this company, Kartos Therapeutics, will be launching in the next few weeks studies in myelofibrosis and PV with an MDM2 inhibitor. BET inhibitors are going to be very interesting, and I think will be coming up in terms of myelofibrosis therapy. There are a number of these, and there have been reports from Ross Levine and others of their benefits in cell lines in combination. Just want to show you some data from this particular agent. Again, it's confidential, so I can't show this slide online, but I just wanted to show you some kind of hot off the press data. So here are 2 patients with myelofibrosis actually treated by John Mascarenhas with this drug. 1 patient's platelet count normalized and the hemoglobin went up. And this patient, who received multiple transfusions before and following initiation of the drug, achieved transfusion independence for at least 6 months. So again, studies with this drug alone and in combination with ruxolitinib will be coming, and we should welcome them. The problem with combinations, though, is our problem in catching up with science. We really must understand who we should be testing and how are we going to demonstrate benefit. And that's something that we as a clinical community need to really be working on. There are studies that can be done, however, beyond pharmacological studies. Ruben had a very nice section in his presentation on this, and I want to use another analogy, which is this mosaic study. This is a study that was supported by MPN Voice and will now be opening more globally in Australia and in North America, looking at epidemiology. And we've learned a lot from this study already, and it pertains to your question about why do patients get the JAK2 mutation. I lastly wanted to end on what the role of MPN advocates in trials might be, to perhaps be a little bit provocative. In my view, trial design should be informed by the patient voice. What is acceptable for patients to undergo in clinical trials? How often should they be coming for visits? What are the questions that the patients want answered? The landmark studies that you'll see presented this afternoon really put across a difference in the perspective of the clinicians and the patients. It's important to inform patients because many patients I see go, okay, Prof. Harrison, whatever you think, if you've got this trial, it must be the best treatment for me. A clinical trial is not always the best option for a patient. And we have a role in educating patients that that is the case. There are some patients for whom there are no other options, but there are many patients for whom standard therapies are a much better and safer option. Equally, it is important to try to improve access to trials. I've heard from many delegates in this conference that they don't have access to standard therapies or clinical trials in their countries, and we should be lobbying pharma to allow that to happen. It's also important that we partner with you in disseminating results, and I think that's about all I have to say, other than thanks to all of you, my colleagues and global collaborators. Thank you.